Welcome to the Pediatric IBD Digest, an educational podcast on pediatric inflammatory bowel disease, including Crohn's disease and ulcerative colitis. This podcast is designed for healthcare professionals, patients, and their families.
We, your hosts, Dr. Tracy Coelho and Dr. Chris Bakewell, both pediatric gastroenterologists, explore key topics with expert guests, offering insights, practical discussion, and the latest perspectives in the field.
But please note that all views expressed are for educational purposes only and don't replace professional medical advice. For personal medical concerns, we strongly encourage you to consult your healthcare provider.
Happy New Year, everyone. Hope you all had a lovely Christmas. Chris, I trust you survived the annual marathon of food, family, and forced fun.
Yes, Happy New Year, everyone. Christmas was great. I hope yours was too. I have to say, having a few days off felt pretty amazing. I almost forgot my hospital login. Bliss while it lasted.
Same here. No on-calls, no podcast recording, no inboxes checked. Well, the last part is a complete lie. But anyway, here we are, back again. Our listeners will be pleased to know that, as promised, our guest from the last episode, Professor Lissy De Ridder, is back with us today to talk about the real-world use of biologics.
So, listeners, don't feel too bad if those New Year's resolutions have already gone out the window. We can provide your Christmas detox with plenty to take away from today's episode. Maybe even enough to inspire a bit of a practice shake-up in the new year.
So whether you're easing back into work or still pretending you're on holiday, let's get started. As we welcome 2026, we are delighted to be joined once again by Professor Lissy De Ridder to explore the real-world use of biologics.
Thank you very much, Lissy, for joining us again. Now, we haven't given you much of a break, I'm afraid, but you may be pleased to know that we're moving the conversation from research to clinical medicine, and we're going to discuss an extremely practical topic of when to switch biological therapy. So we have a lot of questions, as I'm sure you understand, so let's jump in with a clinical scenario. Imagine, if you will, you're in clinic and you have a patient who's presented or who's in your clinic with Crohn's disease. They're established on a biological therapy. For the sake of this, we'll say infliximab. And the family are in your clinic concerned that the treatment, which had worked brilliantly for many months, is now not effective. So from your perspective as their gastroenterologist, how do you determine if the child is beginning to lose response? What are your clinical biomarkers or your sort of lab tests that you would use to rely on in that context?
Yeah, so that is a great question, and that is not very easy to answer, actually, because there are many aspects that are important. Obviously, there are not many drugs licensed for the use in pediatric Crohn's disease, so we have to be very cautious to keep the ones that we have working as long as possible. The patient or the family fears that something is going on. It's crucial to evaluate what is going on. So is it indeed worsening of Crohn's disease, or is something else going on? Is there a intermittent infection, for example? So it's very important to evaluate, exclude other things that are going on. And I wouldn't say there's one clinical symptom or one biomarker that I would base my decision on, because it's really the combination of both symptoms and biomarkers. And then, the fecal calprotectin definitely plays a role over there too.
Now, I wax lyrical in Southampton about us needing to do more calprotectins. How do you get your children to do it? Do they come with a stool sample? I'm eager to know how the Dutch do it.
Yeah, so many Dutch don't do it. So I think they may be the same. So I asked for many more stool samples than I received, for sure. And some families really bring it frequently, and others are much more challenging. So I don't know if that's very much different from the UK setting. Probably not. I think so.
Sounds the same. Once they leave the room, you'll never see the stool.
Absolutely. Sounds like the same theme. Anyway, getting back to our discussion on biologics. So for our listeners who may not be familiar with the terminologies, when we talk about primary non-responders to biologics, we mean patients who don't show any clinical improvement after starting treatment. And then we have a partial response, and then we have secondary loss of response, where patients respond initially, but later worsen despite ongoing therapy. Now, we have seen big landmark studies on this, but it would be nice to hear your real-world perspective. Now, based on your experience, and of course what the literature says, what do typical rates of primary non-response and secondary loss of response to anti-TNF agents looks like in pediatric IBD? And also, when it comes to mechanisms, I'm sure there are lots. What's driving it most often? Is it immunogenicity, subtherapeutic levels, mechanistic failure? What's your take on that?
Yeah, so thank you for these questions. So the large majority of children do respond to anti-TNF when started in the correct dose for that patient. I would say that in my experience, maybe 10% does not respond, but a large majority, fortunately, do. However, there indeed is a group that, despite this initial response, lose response. And I think it also shifts it a bit. By now, we know the importance of the right dosing and the intensified schedules to really keep our patients on the good trough level. So while in the beginning we more often saw immunogenicity playing a role, that has become less. So I would say that if there now is secondary loss of response and other things are excluded, and the therapeutic drug monitoring has been performed, so the patients have been optimized, etc., then it's mostly mechanical, I would say.
And from your experience, the reason why immunogenicity is becoming less of a problem, is that because we are using biologics in combination with immunomodulators such as azathioprine, methotrexate, mercaptopurine?
So I think that is one of the reasons, because we mostly start in combination treatment, but also because we know that it's important to intensify the schedule. So the dosing according to the label, the 5 milligrams per kilograms, 0 to 6 weeks, we all know that is insufficient in the large majority of our patients, especially in the smaller ones. So we don't start them on that schedule anymore. We really start them on an intensified dose. So I think that decreases the immunogenicity. Yes.
Yeah. Now, I was curious to hear your perspective. In the adult practice, the use of subcutaneous biologics is becoming the norm. What's the situation at your end? Is this trend catching up in pediatrics, in your practice as well? Now, we are certainly trying here, but the logistical challenges remain.
Yes, so we started with the subcut indeed. So we offer it to the patients that are on anti-TNF and are doing well, are in remission. And I think that approximately half of patients, or maybe a bit over, wants to change from the intravenous administration to the subcutaneous administration. And once they do, then the majority of patients really like it a lot, because it gives them a lot of freedom and it saves them a lot of time not having to go to the hospital. But for many patients, it is a step, because they are used to this medication. This is what they trust, what keeps them well. So there is also a group of patients that prefers to stay on the stable scheme that they are used to.
Yeah. So with regards to the subcut infliximab or other biologics, I'm sure with your investigator-initiator trial hat on, you will have lots of ideas to work in that direction, I suppose.
Yeah, so one thing that we already did was collecting the data of our patient group and of the Scottish patient group. We now submitted that to a journal, and probably the data will be out to all of us soon.
Thanks, Lissy. I just wanted to pick up on a really important point, because listeners, many of them might be trainees, about the use of biologics, because we differ, I think, quite a bit from adults, and I'm sure it's the same on the continent as well, because we don't have access to a huge range of biological or small molecule therapies. So the use has to be perhaps slightly different, preserving therapy and making sure that it truly has failed if it's going to fail, optimizing where you can. And we talked a bit there about how you do that. So the next question naturally is, when a child does flare on an anti-TNF therapy, specifically, how do you distinguish between those that you just need to up the dose or optimize, and when is it the time to switch? Because of course, for many children, they will have to switch at some point. Are you using that therapeutic drug monitoring? You've alluded to the fact that the dosing is different, and we actually should really be using higher doses potentially, especially in younger kids. Could you just kind of talk us through your decision-making hierarchy?
Yeah, so therapeutic drug monitoring is important in those treatment decisions. I think they're much more important than in the adult field. For several reasons, because our patients have this lower body weight, but also in general have more extensive and more severe disease. So there are just more reasons to be prone to the risk of underdosing. Indeed, in combination with the fact that we have so little options. Do your proactive therapeutic drug monitoring as now is in the guidelines, and also use reactive therapeutic drug monitoring when you are doubting whether the patient is flaring because of underdosing or another reason, is very important before making the choice. Should I continue? Thanks. Should I intensify? Or should I switch to another drug?
Thank you. And as Chris has mentioned, we are seeing more and more advanced therapies entering the mix. Some licensed for children, others still not. So in the Netherlands and more broadly across Europe, what does EMA-approved landscape look like for kids who need a switch? So for our listeners, EMA stands for European Medicines Agency, the regulatory body overseeing approvals for medicines. Now, could you walk us through which agents like vedolizumab, ustekinumab, risankizumab, and other ARBs, if there are, small molecules, those that are not just approved, but realistically accessible in the pediatric practice?
Yeah, so thank you. So infliximab and adalimumab obviously has been approved quite a while ago for the use in pediatric Crohn's and ulcerative colitis, but they have sort of the same mechanism. If we then focus on biologic with another mechanism, such as ustekinumab. Then there is some good news now also, because ustekinumab recently has been approved for the use in pediatric Crohn's disease from the age of 12 up, and from a body weight of 40 kilos up. When we then talk about vedolizumab, and that is a biologic agent that we all use a lot already, especially in the field of pediatric ulcerative colitis. Very safe drug, in many patients very effective, but that unfortunately is still off-label, which is a bit mind-boggling actually, because by now we have so much experience. There is the VedoKids paper, also the industry-initiated trial has been closed already, so we are waiting for the data to come out, etc. So I would actually have expected it would be registered already, but we're still waiting for that. And another interesting thing is when we then focus on risankizumab, then it's interesting to see that in the UK, the risankizumab has been registered for 16 up. That is not the case in Europe. So in Europe, risankizumab for pediatric IBD use is really off-label still. So it really depends per biological agent.
And what about small molecules, UPA and?
Yeah, so of course the tofacitinib and the upadacitinib by now are available for part of our patients. And these are the drugs that do manage to get them under control, so very important, but off-label, and it will take a while before that will change, I expect.
Yeah. And as clinicians, we come across difficult scenarios and we have to prescribe off-label drugs. So when you do that, do you get stick from your local commissioners for prescribing off-label medications?
Yeah, so that is something that is quite varied per country within Europe. So in the Netherlands, we have the fortunate situation that if we can explain why this drug really is needed, then we have access to it. And there are also criteria that, like we tick the box of having refractory disease, for example, that gives us the possibility to prescribe, and then it's also reimbursed for the use in these patients. But that really differs per country. So I often hear stories of colleagues that have much less access to these type of drugs, unfortunately.
Yeah. And, every patient is different. So when you are in the clinic deciding what treatment to start next or even what to initiate, how much does disease phenotype change what you choose? For example, fistulating or perianal disease, if the child's got growth delay, small bowel versus colonic disease. Can you just talk us through a bit about that for our trainees?
Yes, absolutely. So perianal disease obviously has this high preference for anti-TNF medication. That is really by far the best drug. Obviously in combination with also surgical treatment if indicated. But if we really focus on the medication, then anti-TNF is under one or second and on the third place. And when we then talk about growth failure, for example, because that was the second category of patients that you mentioned, So in a patient with growth failure, you shouldn't lose too much time anymore, because you really want your patient to have the ability to catch up before that is not possible anymore. Actually, anti-TNF may be a good choice too. I would not lose too much time in starting on immunomodulatory drugs such as azathioprine or methotrexate, because the chance that really provides such good remission that the child catches up growth. So then you should not lose time. And then a third category was more like the small bowel versus the colon locations. So that is a bit more challenging actually. But in general, patients that present with more small bowel localized disease may have more benefit of dietary interventions, while in a patient that has colonic Crohn's disease, that depends a bit on the type of inflammation, actually.
Yeah. And have you had any real-world experience of using vedolizumab as a first-line biologic? Because, of course, that's been in the literature for some time now, but perhaps not really in clinical practice, finding the right patient that needs a biologic but can wait 3 months or so to have the response.
Yeah, so that's a good question. I don't have the answer for that. So it depends whether the patient has ulcerative colitis or Crohn's disease. So in a patient with ulcerative colitis, vedolizumab absolutely can be a very good drug choice. So when we were working on the UC guideline, which has been revised quite recently, we also discussed how we would sequence the use of vedolizumab, because maybe it's even better to start vedolizumab in patients with ulcerative colitis in need of a biologic agent before anti-TNF. However, since vedolizumab just is not registered yet, we cannot sequence it before the use of anti-TNF. So for Crohn's disease, it's a bit different, because in patients that fail anti-TNF, I wouldn't necessarily choose vedolizumab as a next drug. But it may be so that in the patients that haven't failed yet and have less extensive disease may benefit well. So in some patients, there are special reasons to start it earlier, and I have seen some good response. But for the higher number of patients, actually, I wouldn't know that at the moment. So that's really something that has to be studied, maybe in an investigator-initiated trial in the future.
Sounds like a plan. So for better or worse, anti-TNF alpha agents still occupy the center stage in IBD management. And as you have mentioned, treatment algorithms may change in the future. Who knows? And if I move on to my next question on thiopurine monotherapy in adult IBD practice, which has clearly fallen out of favor over the years, and the 2025 BSG guidelines clearly reflect that shift. Now, from what I understand, the same trend is seen in pediatric IBD practice in North America and elsewhere. But in contrast, many pediatric gastroenterologists in the UK still use thiopurines as monotherapy when they remain effective. Now, what's your perspective on this difference in practice?
Yes, so actually, I think it's interesting to see that in the adult field, azathioprine is used less and less, and that is less the case in the pediatric field, because especially in the younger patients, we know that in general the disease is more extensive and also more severe. And In the younger patients, it's even more crucial to really achieve full remission and also keep our patients well, to let them grow, let them develop, let them be able to go to school, etc. Unless a patient really has mild disease, I think that we shouldn't waste time and really treat our patients well. And that's also something that I've seen in daily clinical practice in many patients, and in the trials that I've performed. So in the Digest trial, where we randomized patients who either anti-TNF started at diagnosis or azathioprine maintenance starting after inducing remission with exclusive enteral nutrition or steroids. We followed up all patients for 1 year, and even by now several years thereafter. So we now have 5 years follow-up data, and paper is now under review. So coming up soon, I hope. But actually, there are only very little patients that remain on azathioprine with a proper control of the disease. Probably we will follow the adult field, would be my guess, more and more.
Yeah, I wonder whether part of that is because, of course, for severe IBD, it's obvious. But for the children where they're borderline, many of them maybe in their teenage years, coming in for infusions is a big time commitment, losing time with schoolwork, exams, relationships, things like that. I think it's a very difficult decision in a world where almost all of our biologics are given by infusion or injection, to choose the right one. I do wonder, maybe if you fast forward 50 years and we have more oral therapies like these small molecules, maybe that decision making is much easier, because then it becomes very clear what the treatment is needed, because you can give them something that they can take at home in their day-to-day life and not miss out on certain things that feel very important for those kids.
Yes, absolutely. And the needle, and that it has to be given with a needle, whether it's IV or subcutaneous, that is, of course, an extra hurdle for children. But because the subcutaneous formulations now are also more available, that will also help and probably lower the threshold of starting this treatment, I expect.
Yeah. Having said that, thiopurines are so much cheaper, even compared to mesalazines. But anyway, it's time to ditch them if we have to. Now, whilst we are on the topic of thiopurines, do most of your patients who are commenced on anti-TNF alpha agents typically receive thiopurines or methotrexate right at the beginning? Or when do you start? For children who respond well to anti-TNF therapy, do you consider withdrawal of thiopurines like after 12 months or 24 months, or do you just continue both?
Yes, so if I start patients on infliximab, I usually combine that with azathioprine, as is also recommended in the guidelines. Usually, after 6 months of combination treatment, when patients are in remission and are doing fine, then I, in general, stop the azathioprine, because after those 6 months, then the risk of immunogenicity, because that is the reason why I start them on combination treatment, is, I think, so low that it's possible to be able to continue on monotherapy from then on. So I probably stop the azathioprine a bit sooner than is the case in the UK, as you said, 12 to 24 months.
And what do patients prefer? Do they prefer azathioprine discontinuation over infliximab or the other way around? Because obviously one is an injection or an infusion and the other is a tablet.
Yeah, so I often discuss that with the patient. So if it took a while for the disease to really be in remission, I feel it's just preferable to keep them on anti-TNF, but it also can be the other way around, that the disease was very fast on a very good control, and that it's more convenient to be on an oral drug. And indeed, azathioprine is much cheaper, so it may also be the other way around. So it's not default to always stop the azathioprine and continue with the anti-TNF. It can also be the other way around.
Yeah. And on that note then, for patients that have been stable for a decent amount of time with their IBD, managed to make it into remission, clinical or biochemical remission, what would be your approach to stopping a biologic therapy? It seems tricky to know which patients will do well and which patients won't. Do you have an overall approach?
Yeah, so my overall approach is, of course, that the patient has to be really in very good remission with low calpro, and preferably also an endoscopy really showing mucosal healing, and also a good conversation with the patient and the families. But if patients are doing really well, if the patient has been on anti-TNF for half a year or longer, if they really understand the need for close monitoring and that they report back if things are not going the way it should, then I do discuss the option, because patients and families, or at least part of them, they really want to try to be without the biologic or the medication that they're on. And if you treat in a proper way, nice and schedule, and then under the good circumstances stop, but have to restart, unfortunately, because the patient flares, and in general, the response also is good on the drugs again. So I think that is a reassuring part.
Yeah. And do you think, based on that response then, would it usually be the family's preference to come off? For example, would you proactively seek these patients that you're seeing in clinic, if they have been stable clinically with a negative histology maybe, that you approach them about stopping biological treatment in pediatric years?
No, I wouldn't. In general, I would not do that. So it's the patient and families that really ask, can I stop? And then I discuss, because chances of flaring are quite realistic. So I would not offer that option, or not on a usual base by myself, but more if patient and families really want to be on that drug holiday, or how they call it.
Very interesting. I must admit, your approach of stopping thiopurines within 6 months is quite novel to me.
After 6 months. After 6 months of combination, approximately. Yes.
And while we're on this topic of thiopurine de-escalation or stopping altogether, may I just mention about our teenage patients who are feeling well or otherwise, they have actually stopped taking the medication themselves. We checked their azathioprine levels and surprise, surprise, the levels are completely undetectable. So we don't need to do anything, job done for us.
That is also recognizable, I must say. Yeah.
Going back on the new adult BSG guidelines in the UK, they do not recommend therapeutic drug monitoring in non-TNF alpha biologics. I suppose that is mainly due to insufficient evidence rather than big-time studies. Now, I must admit, in Southampton, we have continued our practice of doing TDMs, even in the non-TNF biologics, whether in a proactive or reactive way. Now, what's your approach with regards to that?
Yeah, so that is also a learning curve, right? So for the anti-TNF, it took a long time before the value of that was acknowledged in the adult field, I would say. In the pediatric field, we much earlier realized the importance of that. So when the vedolizumab and the ustekinumab came available for our patients, I also started to use TDM also for my own learning curve, I would say. So for vedolizumab, by now we know that it probably does not add much. Ustekinumab is a bit different. So there is evidence for exposure effect. So there I still may use it, but for vedolizumab, on a regular basis, I do not use it anymore by now. But that is next to the studies that are ongoing, also my own learning curve on how to make the most of it in daily practice, I would say.
Sure. Now, I've saved the most controversial question for last. In truly refractory pediatric IBD, there's been some talk in recent years and some publications about combination strategies. So, for example, I guess the most common at the moment might be a biologic and a small molecule like a JAK inhibitor. Do you see these as realistic treatment strategies, or would it still be very exceptional to use those kind of treatments?
Yeah, so I think that for a small category of our patients, it's a very valuable option. But I do think it's important to be critical on that, to be aware of the additional risks of combination treatment of those kind of schedules. And I also think it's important that the teams that are using these kind of combination treatments really are experienced, are aware of the extra risks, and that all other options have been tried. I do have patients that have gone through many challenges, that were on anti-TNF for a while, then failed, had quite severe Crohn's disease, a lot of complaints that now are in combination and actually do very good. So for this small category of patients, it clearly is of added value.
And if you don't mind me asking, what combination do you find works in that context, or is it difficult to know given the patient numbers?
Yeah, so I think it's important that as a physician or as a team, you have your own strategy, so you learn from what you are doing. So in the setting that I've used most, it was the TNF, anti-TNF, secondary loss of failure, and then with JAK started. So mostly, for example, infliximab or adalimumab in combination with JAK inhibitor that works nice. That, but also the combination of anti-TNF together with ustekinumab. That's also a combination that in quite some patients works very well, probably because they really use different pathways.
Do you give them at the same time? What's the regime?
So then usually yes, it's at the same time. Yes, because it's easier for the patient and the family.
Fantastic.
Yeah.
Interesting stuff.
Yeah.
Yeah. I think a commissioner should listen to this podcast. Perhaps it might help loosen some of the red tape around dual biologics. Who knows?
Yeah, but still for a small category of patients,
We'll put a warning at the end. Yeah.
Absolutely. Yes, we shouldn't do that on a routine base, obviously.
So, Lissy, this has been a fascinating discussion packed with practical insights and plenty of food for thought. I'm sure it has given our listeners a few New Year's resolutions when it comes to IBD practice. Thank you so much for joining us on the podcast and wish you a very happy New Year.
Thank you.
Thank you so much for having me, and also a very happy New Year.
Thank you. Dear listeners, as we kick off 2026, here's a short verse from me. To all patients and peers or my partners in crime, if the bygone year didn't quite chime the cherished charms of a happy time, here we are now, so gaze ahead in the brand new year, vibe in the chorus of a joyful rhyme. Happy New Year!